Okay, welcome everybody. We're just going to wait a couple of more minutes for some more people to join and then we'll be commencing. Okay, we're going to commence shortly. We're just letting a couple of people come in to the room and then we'll commence. Okay, I think we'll kick off now. Welcome everybody. Welcome to GP Club. It's exciting to be onto this interactive platform that we're on tonight. I'd like to acknowledge the local custodians of land, which I'm sitting on this evening, which is beautiful Avoca Beach, and honour elders past, present and emerging. I'm Melissa Wilkinson from the Hunter New England Central Coast Primary Health Network. I sit in the education team on the Central Coast. So welcome everybody. Thank you so much for being here. We've got an exciting night planned. It's going to be as interactive as possible. We are being recorded and you will be recorded in the main room, which we are now sitting in, and also in the breakout rooms. When we go into the breakout rooms, we're going to ask you to remain in those rooms and we will rotate the presenters, so you don't have to worry about coming in and out of those rooms. It'll be all done for you. I want to thank all the presenters for being here this evening. Just some little tips about how to use the meeting tonight. So we want to make this as interactive as possible, and tonight will involve some breakout rooms, currently in the main room, as I've just said, but when we get to the skills stations, you'll be automatically allocated to your breakout room. So there's nothing that you need to do. Just make sure when you have a question, if you could please raise your little hand on the icon up the top of the screen under reactions, and then unmute your mic to ask your questions to your presenters. So we will be having a networking session to start and you'll be in your groups, then we'll come back for the main presentation and then we'll be going back out to the breakout rooms. So, and the stations will happen then. Please keep your cameras off and your microphone on mute whilst in the main room. If you'd like to ask a question, as discussed, just remind you to please pop your hand up and unmute yourself. It gives me great pleasure now to hand over to Georgia Page. Thank you for being our facilitator this evening, Georgia, and our lead for our vertical integration program, pilot program, which is going amazing and very successful, getting some great response from that as well. So Georgia's a GP at Your Family Doctors and has been involved in medical education, in training and supervision of GP registrars for over 10 years. So I'm going to hand over to you now, Georgia. Thank you.
Thank you, Melissa, and welcome everybody to our second GP Club. For those that are new to GP Club, so these are networking and educational evenings that we hold every few months, where GPs, registrars, JMOs and medical students can meet and greet, learn some clinical skills at the same time, and hopefully eventually we'll be able to share a meal together as well. So the idea of GP Club is usually to meet with each other on site, but due to COVID, this session and like the first session we had was converted to online, but luckily we are all very adaptable. So our first session was on dermatology and went well, and this session will be on ears and eyes, which is an area that is very important in general practice, but often isn't taught as well in the medical school or you know, JMO sort of environment, and it's always good revision for us GPs as well. So so the aim of tonight is to initially we'll be networking, going into groups and just chatting to each other. Hopefully we've got a great range of participants, ranging from very experienced GPs to JMOs, GP registrars and medical students. So it'll be great for us to network, get to know each other, and then we'll cross over back to the main room with Julian telling us about his special interests in ear medicine, which he's done some extra training in as well. So when we've got enough of us on board, we'll go into our little rooms to have a little bit of a chat. This session does go for a while tonight, so make sure you stand up, stretch. If you need to get something to eat, go for it. Yes, we'll go from there. So I'll see how Todd's going with the rooms.
Yeah, I think we're actually looking pretty good.
Great.
I think there'll be a few people, just so you know, that who may not necessarily go automatically into a group. But if that's the case, you'll be in the lobby with me anyway, and we'll assign you as we go. So thanks.
No worries. And certainly the last 2 years have been difficult because we haven't had many face-to-face meetings. So especially for the new GP registrars or the JMOs, you haven't had an opportunity to meet a lot of the GPs on the coast. So this is a great opportunity to do that.
All right, I'll open the rooms for you now.
Great, thanks, Todd.
Welcome back, everybody. Now we'll hand over to Julian for the main presentation. We're commencing in a couple of minutes. We'll just wait for the others to come back in.
Now I can hear you, Mel, but I'm on a blank screen. Okay, we're getting everyone back in again.
Yeah, how you doing, George?
Yeah. I had to log back in again because.
Oh, right. Yeah, I think I could see you, but I think maybe I thought I was just going to jump back in, but that's not what happened.
Yeah.
Yeah.
Anyway, hopefully I can see names popping back up, so hopefully.
Yeah, there's a lot of crew there.
I had to log back in again too.
Yeah. We've got Karen, welcome, Karen. Hi, Georgia.
How are you?
So I think while we wait for everyone to come back in, and then I'll introduce you, Julian.
No worries. Yeah, it's quite different, isn't it, to doing. I've never actually done a presentation using this system as opposed to like standing in front of people. Quite a different setup.
It is different. It is. It is.
Yeah, just on five, and it's got its advantages.
Yeah, like it's good when you go into the room, you can have a chat, have a good conversation with, just like you're having a little conversation with a group of people. So
yeah.
Good.
Looks like we're getting there slowly but surely.
Very good. So I might introduce you now, Julian, if we've got everyone here. So I had the honour of introducing Dr. Julian Jackal. He completed his junior hospital training at the Hunter region and trained with GP training in Valley to Coast back in the day. And what year did you finish your training, Julian?
You know what, 2007, 8, something like that, I think.
Yep. I think I was 2000.
Around about that.
Yep. And then you worked in general practice until 2021 and has combined medical practice with other interests, including Indigenous Health, ENT and skin cancer medicine. And you're about to tell us all about that and also about the management of common ear conditions. So take it away, Julian.
Well, I'm guessing it's Todd is going to put the, here we go. I've got my little clicker here.
Yep.
Perfect. Yeah, so thanks for having me, guys. I'm Julian Jekyll, and it's nice to get back into a bit of medical education. I haven't done it for quite a while. And I understand I've only had a chat to just a couple in my breakout room, that we've got quite a diverse group of people tonight, experienced GPs and GP registrars, and also I think some RMOs as well, which is excellent. So I'm hoping that for the newer members of the crew, my clicker's not, oh, there we go, it's working. The newer members of the crew, that I'll be able to give you a bit of inspiration to look at general practice as a career path. And for those who've been around a bit longer, maybe just one or two tips that you may not have thought about or heard about before, we'll see. I think as opposed to other specialties, general practice is both the training program and the career, it just takes you in so many different directions. And I've always been someone who's been quite interested in, jumping at any opportunities that present themselves. So I tend to say yes to things that come along. So I'll run through a few of those that I've sort of said yes to along the way in my general practice. I've just got to get my little clicker here sort of jumping in and off, I think, Todd. You might have to do the next one, please, mate. There we go. So I was a late-ish starter to medicine. In the early 90s, when I finished school, quite a while ago now, hospitality was having a moment. So I went and did hotel management at uni, where I guess I learned how to throw a party and pour beers over 3 years, which sort of ended up with me working in pubs in inner Western Sydney. And as a very young hotel manager, it gave me some useful skills, I think, in working with the public in years to come, especially a few years down the track at 3am in the Mater Hospital at Newcastle, in the emergency room. It was, we're not wasted time. And then I transitioned into work as a professional fisherman for a while out of Cairns, and then finally, after a bit of international travel, ended up driving an ambulance in Sydney as an ambulance officer for a year around Marrickville and Mascot and sort of places like that in the midst of the heroin epidemic in Sydney. I guess, and that kind of lit a fire for medicine for me, because I used to sort of have the patient in the back and wonder what was going on, and then I'd drop them off and wonder what the outcome was. Yeah, so the next slide, please, Todd. So after I finished my intern and RMO 1 years, I was sort of eyeing off some emergency training, and I'd done a lot of that and I really enjoyed it, and I got accepted into the critical care year at John Hunter. But I was looking around at the bosses in the emergency room at the time, and I don't know, I sort of thought, do I want to be doing this, when I'm 50? And I can say now that I'm 48, the answer's definitely not. I think I was dead right. And unfortunately, when I decided to jump ship out of that, I'd missed the training GP application cutoff for Valley to Coast at the time. But luckily for me, there was a back door. So this is the first sort of jump towards general practice. So I ended up working in Nelson Bay for 18 months, because at that stage, that was an area of need. I suspect it's probably not now. And so I did that without being part of any training program. Next slide, please, Todd. Yeah, and that was a big shock to my system. I'd done a lot of work in ED. I'd done a lot of ED locuming at nights. So I thought, I'd be fine. I'll just jump into general practice. I should be sweet. It turns out that it was a significantly bigger challenge than I'd expected. The first thing I noticed, I guess, was that I had so much more autonomy, with a little bit of help at times when it was required. So unlike working in the hospital system as a junior, it was me deciding on the plan for the patient in front of me, which in the beginning was quite frightening. And in addition, there were dozens of things that I'd literally never had to deal with before. So the GPs will recognise all these, but the junior doctors, you might not. So ingrowing toenails and random rashes, erectile dysfunction, sexually transmitted infections, skin cancer, and even things as, that you see every day, like anxiety and depression. I hadn't really dealt with those things by myself before, and the list goes on and on. But I could see the potential. Next slide, please, Todd. So to give, I guess, the more junior guys a sense of the options, so both during training and then I think, as you start your career, whilst I was training, as Georgia said, I had an interest in Indigenous health. So I worked at a Wobbical in Newcastle for 6 months, and then later in my training did 3 months at Danila Dilbur in Darwin. And obviously the medicine up there was amazing. So we travelled in a car with a couple of Aboriginal health workers around Darwin, looking after people who were sleeping rough in the dry, or what's called long grassing, and went out to a lot of the communities where most of the Indigenous community, with anyone over the age of 40, had quite complex medical issues, and then we just phone back into the hospital and get advice as required. And you get to know the Aboriginal health workers really well, and they took me out one night, 3 a.m. in the morning, barramundi fishing on a river full of crocodiles with the head torch. So things like that, amazing experiences. During my time in Darwin, the other half of the time up there, I worked in a sexual health clinic or family planning, really. And that was where I first treated syphilis and gonorrhea for the first time. I spent a bit of time back in Newcastle working for Valley to Coast, which was the medical educator before Synergy. And then as far as courses went, I realised from my junior medical years that I hadn't done a whole lot of paediatric training. So I did a diploma in child health, and then that was by the Sydney Children's Network, and then some time in a certificate of dermatology at Monash Uni. Next slide, please, Todd. So my wife's English, and along the way we'd always planned to go back to the UK, really potentially for a long time. It didn't pan out that way, but 10 years ago we moved back to the UK for a couple of years with our newborn baby, Toby, at the time, who's now 11. And there was certainly no issues getting a job as a GP in the UK once that I'd finally jumped through all the hoops that you had to when it was part of the EU. I suspect now, post-Brexit and COVID, that any of you would be snapped up within a second over there. One of the things I found about general practice in the UK is that they tend to work at a much faster rate than here. So the bulk of general practice consults are 10 minutes long, and a lot of them are just one problem consults. But I find in Australia it doesn't happen so much. And they also were using a lot of telehealth, which was non-existent in Australia at the time because we couldn't charge for it. And obviously that's changed now. So it made, I think, doing something like that, heading overseas, made, for me, introduced me to working at certainly a different rate. So it made me faster and more efficient, I think, in practice. And when we did shift to telehealth, I didn't find that too weird at all. One of the best things that happened to me over there was by chance I heard that there was a dermatologist who ran the whole West Sussex dermatology, and they had a dedicated skin cancer service. So in general practice in the UK, you don't really do skin cancer. If anyone gets the skin cancer, you can't do it yourself. You've got to send them somewhere else. They don't even do cryotherapy. They send those to someone in the practice who's got a special, skill with using liquid nitrogen. So it's very different to here. Anyway, I called this guy and teed up to meet him. And I caught up with him once, and he sat me down and showed me a picture of a skin cancer on an elderly patient's leg and asked if I'd be comfortable removing it. And I was like, yep, no problem. So, and that scored me a job straight away. He's like, okay. And then I started working for him once a week or for the service with 2 nurses in operating theatres in peripheral hospitals around the south of England, taking out skin cancers, often which were very large because people didn't know about it. There's no sort of public health around skin cancer in the UK, obviously. There's not a lot of sun. But that doesn't mean they don't get them. And often you find that they're very late when they come to you. Next slide, please, Todd. So at the moment, I work 5 days a week in a skin cancer clinic in Charlestown, in Newcastle, where I do some of the nastiest skin lesions on the head and neck and a small amount of ear microtoileting, which I'll talk about a bit later. I ended up doing this sort of stuff after taking a job quite a few years ago now at the ear, nose and throat clinic at John Hunter Hospital. They were looking for GPs to help minimise their waiting list, basically. And in that clinic, I worked obviously with the local ENT surgeons and a couple of other GPs, where I learned how to do nasoendoscopy and improve my microtoileting skills, and basically just tried to see if people needed an operation or we could sort it out without it. After a couple of years, I transitioned from that into working in the private rooms with the ear, nose and throat doctors locally, in conjunction with working in general practice at the same time. But I do a day sort of once a week or every 2 weeks, doing their public skin cancer referrals that came in through the hospital. It was a strange setup, But essentially what would happen is then they'd get referred the nasty nose, lip, ear patients with big cancers, and then they'd come in and we'd look at them together. I'd sit down with Toby Corlett or Darren Cope, the surgeons, and we'd have a chat about what I was gonna do. We'd draw what the plan was, so a big flap or graft, and then I'd just do it with a nurse in the rooms. So it was for me, great experience, the kind of experience that's hard to get, I guess, to learn more complicated flaps and grafts and things like that. Since then, I've moved on from those guys, and I now work solely in Charlestown, which is ironic since I'm doing a GP talk. But at the moment, I'm not doing any general practice. I'm just doing straight skin cancer and ear work. So for me now, an average week is a combo of skin checks and operations, apart from on a Tuesday where I just do the more tricky operations with a nurse, Lisa, I met in the ENT clinic that I've been working with for 7 or 8 years now. And on Friday morning, I do a full morning of micro-toileting of ears. Next slide, thanks, Todd. There's one other thing I'll just talk about before I talk about that. I realised when I did the slides, I hadn't talked about or even thought about COVID, and we've all lived through it and been working the last couple of crazy years. In fact, I just came out of lockdown for having COVID a week ago. So in 2020, when COVID started, I was working Monday and Friday in general practice and the rest of the week in the skin clinic. And initially I thought that the skin clinic was going to have to close because our average patient was 65 years and older. You know, only very occasionally is skin cancer actually life-threatening in an acute situation. So I put my hand up to do all the spare shifts in GP Access at John Hunter and Belmont. So I was doing 3 or 4 of those a week for quite a few months. I don't know, maybe nearly 6 months of 2020 at the start of the year. And there were certainly plenty of people who wanted to give them away. And it was for me, such a random experience those early days, because there was so much fear, both for patients, I think, and even talking to doctors, and that included doctors in the emergency room and other GPs. And I found it quite kind of intriguing. I guess I was willing to see patients face to face from the get-go, because I figured if I personally didn't do it in GP Access, then someone else would have to, and that usually meant probably the emergency room. But yeah, it was interesting hearing patients talk about their experience just from a general practice point of view, having real trouble getting in to see a doctor, even when their kids were genuinely sick, and then sort of a lot of patients, I guess, and I certainly heard from the ED, that were having to head into the emergency room as a result of that process. Yeah, and I found that quite challenging. I guess my feeling was, you know, as medicos, when we sign up to be doctors, it's hard in the middle of a pandemic to say you're not going to see sick people. I just found the whole dynamic of that really quite difficult. But yeah, as far as general practice goes, it really is the true cradle to the grave experience of medicine. But I would say my experience is you kind of find both your own type of patient, or they find you. So, and by that I mean if you're especially interested in, you know, seeing lots of kids, or you like sexual health, or you like working with the more geriatric population, or mental health, I found that you can definitely develop, you know, your own group of patients along those lines. And depending on what kind of medicine you practice, if you're someone who's flat out, or, you know, you like to listen for a long time, your patients will select you out as well. My experience over time is that you really do develop some amazing relationships with patients and broader families, including multi-generational, obviously. Obviously, you'll have some relationships you're not so keen on, but we all have a few patients that are very tricky. And from a point of view of family life, certainly for me, it's been amazing. So, you know, you can work short hours. I pick the kids up after school. My wife works longer hours than me a few of the days of the week and heads to Sydney, and all those things fit in really easily with general practice. So that's the end of that section, guys. I have to say, having never done that before, it's most bizarre because I can't see anyone. I'm hoping you could all hear me.
So did anyone have any? That was great, Julian. A very varied career there, and I'm glad you've found your groove.
Yeah.
Yeah, no, it's very true. There's so many options in general practice. Now, before you head on to your next part, does anyone have any questions at all to Julian about his career?
Has everyone got their cameras on? Because I can't see anyone. Is
Yep.
there?
Yep. So feel free to unmute, ask a question, show us your face.
Yeah, show us your face, guys. It's much easier. It feels so weird talking to a blank screen. It's so random. That's better. How are you? You might have to unmute, guys, I think.
Julian, can you hear me? Hello?
I can. Yeah, is that you?
I'm John Fogarty. I
How
don't
you
really, I'm GP, and I don't really have any questions. I've got no questions and a million questions, but I just would really, second what you say about how general practice. I mean, I'm right near the end of my career, but for doctors just starting their careers, it's really fantastic to hear from you with such enthusiasm and such a eclectic career and so interesting and interesting life, the stuff that you've been able to combine in general practice and maintain a really good lifestyle with family and all that sort of stuff. And I reckon that's one of the great joys of general practice, that younger doctors looking at the career can, I think if you're a neurosurgeon, you sort of tie
stuff, mate. Yeah.
It's
a shocker.
hard lonely slog. You got to like the inside of the spine, but
yeah.
So it's and we do kind of we don't do it ourselves as a profession much service by complaining and whinging. I mean, I think we're incredibly fortunate. Fantastic job. I mean, I've had a very different career path to yours, but I have the same view that it's been a fantastic career, and with a really eclectic range of lifestyles and options. So that's been very kind to me, and I would encourage other doctors at the beginning of their career who might be tuning in tonight to think that they've got a good time ahead of them.
Yeah.
That's what I reckon.
Yeah, I think that's very true, mate. Absolutely. And I do think, having seen other specialties, and I've got a brother who's a physician, and I can tell you his lifestyle and the demands of being on call, they're hideous. Like, parts of that job are genuinely hideous, Yeah.
Right.
Yeah.
That's right.
Did anyone else have anything else they'd like to contribute or no? So we can see we've got a couple. We've got Dave, you're an RMO. And have we got any other RMOs or? Hard to tell.
KH, introduce yourself.
Oh, KH, yeah, you got your microphone.
Kelly, GP registrar.
Hi. How are you doing?
GBT1 registrar. I have resonated with what you've said. I've loved GP. I didn't think I'd be doing it. Internship and residency, I was telling the group earlier, it wasn't really on my radar. I kind of feel like it self-selects people that are really interested in just like the human condition in general and chatting with people. And obviously the pathology is fantastic and such a wide range. 1 minute you're with a 3-year-old, the next minute you're a 60-year-old, and then there's a mental health visit and an ear like you're about to talk about. But overall, I've loved the first couple of months, and I would really recommend it to the RMOs that are considering it. I've really enjoyed it. Like I said before, I was told it was going to be the scariest 6 months of my life, but I've really enjoyed it. And I'm really glad that I've chosen this path. So it's definitely
Cool. Has anyone else got anything else they'd like to say? Or?
I just say to Kelly and to others that even though you said you thought it was going to be the scariest 6 months, and it wasn't. I think it can be scary, and I think that I know I'm always a bit concerned at our practice with registrars and medical students who are never scared, because that kind of
I have a very good supervisor and it's very well supported. I have no idea what I'm doing, and I'm aware of that. But
I still get scared occasionally. So I think it's if you're a junior registrar and occasionally you think, geez, I don't know, I got no idea where we're going here, and I think I'm in terrible trouble. Well, just get used to that. Get used to that sinking feeling,
And the funny thing is, you ask the supervisors, and they're like, "Oh, I have no idea what to do about that either." And you're like,
yeah, that's not an uncommon feeling. Yeah.
Chances are we don't know either.
But at the same time, just the experience that I've had so far from the range of supervisors in my practice has been outstanding. There's all different answers and all different opinions, and so much to learn. I'm very excited. It's great.
Right, that's great. Glad you-
I might just make a comment, Georgia.
Yes,
Dimity.
go Dimity.
And I'm a recently retired professor of general practice, and I've been doing 2 sessions a week, or 12 hours a week of general practice all the way through, and now I'm back doing a bit more, and I am having a ball being back in general practice. So this is not something that, you know, that comes to an end and you have to retire and kind of leave completely. You can phase out. I'm also I'm teaching domestic violence through a program from the University of Melbourne, and I'm zooming into practices all over the countryside, rural Victoria, Launceston. I've just signed up for another one somewhere. I can't remember where now. Talking about domestic violence to the whole GP practices. And I'm on some committees for making policy around dementia, which is, you know, putting in the GP voice where it needs to be heard. So and the other thing I wanted to say was I have a peer support group, a couple of other GPs around my age who we talk about patients and, you know, issues. I talked about phasing into retirement last time, and I would thoroughly recommend that as a supportive thing. So basically you can continue to learn, you can keep changing, even when you're heading for retirement, you can keep changing and learning stuff, and you can also find support so that you're not by yourself. So so I just wanted to say all that. Yeah.
I think that's a really great point, Dimity, because I think that's what doing medical education as a career choice as well. The one thing I know that medical educators love is having that group of doctors that because you work together, you have that debrief, you have that collegiality and stuff. So I know I would need that if I was working full-time in general practice. You'd have to replicate that. So if you can find that in your practices, I think it's so important, or outside of your practice if you're a group friend. But yeah, because you sit in your room a lot of the day by yourself, it's so important to have that group of colleagues that you can debrief with and, share war stories and stuff confidentially, of course.
Yeah, great. All very great insights. So we might move on to your clinical talk, Julian.
Sure.
If you want to
I'll
start
just
us
say
on
for this,
that.
Georgia, just for the guys, it's probably because this will be hopefully somewhat interactive. So maybe leave your cameras on and your mics, because there's not. I can't see how many people there are. It seems like a few, but maybe leave your don't mute yourself so you can answer questions, because it'll be much easier for me if people are willing to have a punt and say what they think. Because if we were standing there in the room, I'd definitely be asking you guys to contribute. So we'll see how it goes there, because I was planning on you guys feeding back a bit here.
Yep. So don't be shy. Put your cameras on.
Don't be shy. Feel free to speak up.
I've got Ugg boots on. It's okay.
Yeah. All right, Todd. So I guess we'll pop up I think that it's the ear syringing slide. That one, mate, if you're there.
Yep, 2 seconds.
Yeah. So for this talk, guys, it's basically I've picked out some things that are really common in general practice, but even that might be useful for some junior doctors in hospital as well. Things that you're likely to see in emergency rooms and things. Thanks, mate. So I started with this one because it's something that I often see, because I do quite a lot of ear microtoileting, which is basically using a microscope with a little vacuum cleaner to suck stuff out of ears. I see a lot of post-syringing issues, and sometimes I guess ears that perhaps shouldn't have been syringed to start with. So I'll just put it out to you guys. So who should not have their ears syringed? Anyone willing to take a punt? Just name a few reasons why.
So people with a known history of a perforated or an active perforated impediment membrane.
Yep.
That's one.
Any others, guys?
I wouldn't syringe anyone with vertigo.
Yeah, no, that definitely, yeah.
And I think painful ears, I'd be very reluctant to
Yeah, I think yeah, so they're all dead right. I think I'd sort of add to the list, and so I think anyone who's had an ear infection in the last 6 weeks, and that it would include otitis externa, so an infection in the canal, particularly in that instance, water's the enemy. Anyone who's had prior ear surgery, so you shouldn't really be syringing an ear that's had a tympanic membrane repaired or has had a mastoidectomy, so an operation on their ear, or anyone who's even had operations in the middle ear. I think anyone who's had recurrent otitis externa is probably not a good idea either. Anyone who's profoundly deaf in one ear, you shouldn't be syringing their good ear. And same with people with a cleft palate. If you are going to syringe an ear, what should you do beforehand? What are the sort of things? Obviously, apart from taking a history that they don't have any of those sort of contraindications, what would be your approach, guys? If you're going to do it, or you're going to get your nurse to do it?
Soften the wax first.
Yep. So that's a definite big one. Anything else?
Gonna get informed consent.
Yep, absolutely. And would you have a look yourself?
Yep.
Yeah. So I think I would advocate that for doctors in general. Having, I guess, over time, having seen things happen with syringing, I think you'd take a history just to make sure that none of those things that you're worried about from what we talked about before. But I would have a look and see what's going on for a few reasons. I think one of the reasons is sometimes they may not need their ear syringe. They've come in for it, but it might have cleared when they've been using their wax, or the canal isn't actually completely obstructed. So if the wax is not completely obstructing the canal and they don't wear hearing aids, or they're not going for a hearing test, you've got to wonder if you need to syringe your ear in the first place. And as George has said, you definitely soften it first, and I'd normally do that for a couple of nights beforehand, and just use Waxol or Ceramol or something like that. As you said, Cosmos, so you get consent, and when you're syringing, if the patient gets pain, obviously if they're bleeding or they're getting vertigo, you need to stop. And the other thing I'd say is, after the syringing, and this I think especially applies if you guys are getting your nurses to do it, is I think you're probably obliged to have a look afterwards. So you know that nothing's gone wrong, so that there's not now a big perforation or a bleeding canal or drum. And also that you're ruling out other things that you can see once you've syringed the ear out, which we'll talk a little bit more about later. I'll just see if I can, just the next slide, please, Todd. Oh, sorry, down the bottom there, you can see that it's a common reason to get sued. So yeah, you definitely want to make sure you're a bit careful about it, and certainly, patients know what they're in for. Go for it, sorry, mate. So that when you look at that wax, that's going to be a dead easy one to syringe to my mind. That's how you want it to look after you've used a bit of Waxol. That's a nice wet bit of wax that'll come out in 3 seconds flat. Next slide, please, mate. So cotton wool tips, people sticking things in their ears, bobby pins, or the pharmacy endorsed earwax tools, all terrible for ears. So these are all enemies to ears. And you'll find, if you ask your patients, that loads of people do it. Nearly everyone, I'd say. It's pretty amazing when I ask people. The things that they do when you stick stuff in, obviously it pushes the wax back in, which compacts it. When they put something into the ear, they'll often scratch the skin in the canal, which will lead to otitis externa. I pulled out on one lady 3 cotton wool tips in one ear from the tip staying in there, after she told me she'd never used them. So I was like, are you serious? And I have seen a couple of people put a hole in their drum sticking things in there. So I always take the opportunity with my patients whenever we talk about ears to remind them not to stick anything in there. And my blurb is that the ears are self-cleaning. So I tell people, if you stick a dot of texture on the eardrum, that grows out along the skin of the canal wall and then falls out. And so any wax that's made, if everything's working normally, will just fall out without you knowing about it. And if you stick anything in there, that wrecks that process. Obviously, for people who are using earplugs at work or hearing aids or earbuds, that'll stop that process. So they're the people that are likely to need their ears syringed. The only thing that's safe to stick in the ear is a tissue spear. Do you guys know what that is? So that's just the corner of a tissue turned up tight. And it's easier if someone else does it, but you can do it to yourself. You'll know you've got it right if you poke it in and it feels really uncomfortable, because that means you're poking your drum. You can't hurt your drum doing that, but you can mop up secretions. Next slide, please, Todd. So this is a common one that I see a lot of too. So skin conditions really do affect ears. So I see a lot of people, partly because their wax builds up really quickly. So anyone who's got dermatitis or psoriasis, which are really common, will get excessive wax production a lot of the time. So if you get someone whose ears fill up with keratinized wax really quickly after a week or 2 or 3, it's likely that they've got some sort of skin issue that's going on there. Those things will contribute to otitis externa, because if you get cracks in the skin, the bugs can get in. So, and anyone who gets recurrent otitis externa, I'd always have a think about whether they've got a bit of eczema or psoriasis going on. What I normally do for these guys is I'm a big fan of Advantin fatty ointment as a first port of call, just in the conchoid bowl, if someone's got a really itchy ear. And I don't know if anyone's ever used David Bet gel on the conchoid bowl of the ear, but we've probably had about 15 or 20 patients in the clinic who had really significant wax build up really quickly. And Dr. Jenny Broughton sent one of our patients off a few years ago now to the ENT surgeons. No joy, they didn't know what to do. Sent him to a dermatologist, and that guy actually put our patient on David Bet gel into the ear canal. So I'm not saying you guys should necessarily do this, but they did it once daily for 2 weeks, and then once every second day for 2 weeks, and then once a week for 2 weeks, and essentially stopped the problem. So this patient was coming in to have their ears microtoilet every week or two for months, and it resolved. And since then, I've probably done that with about 15 or 20 of our patients that have had real issues. And I'd say for 3/4 of them, it's been life-changing. Some of them haven't had to come back. So I'm not saying that you should stick David Bet gel in the canal. If you look it up, there's no contraindication to it. But probably the way to use it is just to put it in the conchoid bowl, and I just use it like you would elsewhere. So use it once a day for 6 weeks and see how you go. And often you'll find that itch and things will settle down. That's if the Advantin doesn't work. Next slide, please, Todd. So that's a picture, a pretty simple one, that could be eczema or could be psoriasis, but that's the kind of thing. But often you won't get that picture, and I find a lot of people will have psoriasis that involves just the ear, and they won't have had it anywhere else. Next slide, please, mate. So you would have all seen this at various times. So the otitis externa, the common way to present, you can see there in that first slide, is the narrowing of the canal. The second slide's a good picture of like keratinized material inside the canal, which is what happens when they get the infection. And on the far side, you'll see the really obvious fungal otitis externa, which essentially looks like bread that's gone off, So you can get green, you can get white, you can get all kinds of different spores. It's pretty gross. Yeah, so pop on the next one, please, mate. Next slide, Todd. Thanks, mate. So the question I've got for you guys is, what are some of the historical clues that it could be otitis externa, and what would you sort of find on examination of the patient? Anyone willing to have a punt?
So often it would be painful on pulling at the ear. Pain.
Yeah, so moving the pinner will usually be painful, whereas with otitis media, that's not usually the case, like very rarely. And obviously you'll have a swollen canal often as well, and you might have some discharge. So that's the examination. What about the historical sort of, what's the natural history of someone who's likely to have this sort of stuff, otitis externa?
It's often recurrent.
Yep.
And there may be associated history of atopic eczema or some form of eczema as well.
Yeah, definitely skin. And I'd say that the really common, the common history that I get certainly when I see people is that they're either swimmers or surfers. Sometimes it'll happen when people go into places where it's really humid. So even locally when it's really humid, you'll find because of moisture, bugs love that. Anyone who's been sticking something in their ears is a dead ringer for getting otitis externa. And certainly if they've had a history of it in the past. Should you syringe it? No, so I know some GPs have, because I've certainly seen it happen many times, but I reckon you probably shouldn't, because I think if anything, it just aggravates the problem. And if you can't get a good look in there, you certainly shouldn't be syringing, because you're not sure exactly what's going on. If in the GP clinic, how would you guys manage that? Someone came in with a bit of a mucky ear, you thought it was otitis externa, you saw they'd been swimming, what would you do?
This is the tricky part.
If you take your microphone mute off, you'll be right to go, mate.
Treatment will depend on how you assess the severity.
Yep.
For people whose ear canals are threatening to close up, you might want to insert a wick.
Yep.
And review them in 24 hours and continue with topical treatment.
Yep.
In some people, their ears might just be quite swollen that you might have to combine topical treatment and oral antibiotics and some analgesia to manage them. It's important to remove any secretions with a tissue spare.
Yes, yeah.
Where possible.
Yeah.
As much as you can, and also to be aware that at times some of them could progress quickly and may need different options of treatment. If it were to be spreading and involving the soft tissues around the area. So
yeah, I think that sounds all very sensible. I agree. I think you need to clean the muck out, and a tissue spear is the best way to do that. If the canal's quite wide open, and often it is, even if they've got an infection, I wouldn't normally use a wick if you can get drops in there easily. The drop I'd use to start with, if there's no perforation, would be Sofradex. And you don't want to use them for too long. So I think 4 or 5 days, or even 3, is sometimes enough. If they've got a perforation, then you'd preferentially use Cipro. I think a wick's a great idea, mate. If the canal's narrow, like that first picture, I probably would put one in there, because it's very hard for the patient to get the drop in. I wouldn't commonly use oral antibiotics for otitis externa. I'd do that very rarely, because I think you'll find if you put a wick in and you use drops, so unless the patient's got a good going cellulitis, then I think if you're looking at that, then that patient could be quite unwell. So they usually have a lot of pain, high fevers. They might be diabetic. That might be something that needs hospital review. If they're that bad, I think you can often get away with a wick and topical antibiotics and catching up with them. In general, you'll get on top of most things with that. You need to give them some pain relief, because it's often very painful. I think you're dead right, mate. Those that you're having a bit of trouble getting on top of, so if it doesn't settle down, that person is likely to need review. And sometimes microtoileting, this is the time where that would be suitable, because one of the things you have to do is get the muck out so that the drop can get to the skin. If you don't do that and the ear fills up really quickly, then you're on a hiding to nothing, really. If you're sticking something in there and it's not going in, it won't work.
Julian, can I ask 2 questions? So first one is, because I always find they're really tricky, because obviously we're told not to use Sofradex, or I guess aminoglycoside in a patient where they have perforation, but a lot of the time you can't see the TM. And when I've talked to ENT surgeons, like, most of the data is with long-term use. So just your thoughts on using Sofradex when you can't see it. And the second one is very simple. When you put a wick in, how many days do you leave it in before you take it out? Because it's very hard to find that written anywhere. I've looked in the past.
I think the answer to your first question is if you look at the therapeutic guidelines, up to my last reading of it, and I've looked at it so many times for this, is that you can use Sofradex. And if you've got a perforation, it probably doesn't matter. I think the evidence is it's unlikely to cause someone to go deaf, for a short. So if you're worried, you could do that. But if you think they may have a perforation, or they have in the past, the ENT guys, I can tell you, in general, would give someone Cipro.
That's what the exam question would say.
They often just use ciprofloxacin off the bat. So, but I would normally use Sofradex first. Yeah, but you're right. You often can't get a good look at the drum. But usually, unless the person knows they've got a perforation, if they've just got a standard otitis externa, there's not really a reason they'd have a perforation. The answer. So what was the second question, mate? Was
Sorry, it was just so you put a wick. So you're in general practice.
Yes. Mate, it'll fall out, Chris. It'll fall out.
Oh, right. So you just leave it until
if you put a wick in, invariably It depends on how soon you want to get the patient back. So if you're really worried about them, yeah, you can have a look the next day. Once the infection settles down somewhat, the canal swelling goes down and the wick will usually just fall out. There's no harm in leaving it in a couple of days, mate. Yeah. And sometimes they stick in more than one. The ENT guys will put in more than one wick. So, yeah. Okay. One thing I would say is they're bloody painful things to have put in. Just be aware of that when you do it. Yeah. I haven't found a brilliant way. I've tried various things over the years. I've stuck straight local anaesthetic, a couple of drops in the ear, and that does numb it up. But then if they've got a hole in their drum, I think I've put one in someone who had a perforation, and that is not good. She became really vertiginous really quickly. So I've stopped doing that. I did that about, I don't know, 7 or 8 years ago. So it is hard. Just be aware that it is painful. Yeah.
Cool. Thanks.
The other thing is if it's not getting better. Oh, so sorry, on fungal infections, that third picture on the slide before, those guys, if you can't get it out, they really need a few things. So no water in the ear. Often it'll be at the back end of having a lot of otitis externa. So if they've had lots of drops, they're very likely to have a fungal component. And they probably need their ears suctioned. So microtoileted, you've got to get all the junk out. And then my preferred drop by far is local cortin Bioform. I don't know, it's very hard to get a hold of, but you can get it made up at a couple of compounding. But that seems to me to work the best. So 3 drops twice a day for a week. But you've got to clean the ear out, get the skin there so you can get the drop in there. And they can be really hard to manage. So if someone's getting that recurrently and they've had it, they're very likely to get it again in the future if they get their ear wet. So I'm pretty hardcore with people with otitis externa by saying no water in the ear except the drop. And that would include when you get in the shower, just get some cotton wool balls, dip them in Vaseline, stick them in your ears, chuck them away. Definitely no swimming or anything like that. And for those guys who are getting recurrent otitis externa, it's in their best interest to if they're going to get in the water, to plug up and things for a couple of months. Toby Corlett gets people to put in aqua ear once a week, just to dry it out after it all settles down. So they're the sort of things that you could do. One thing I would say, if it's not getting better, so you've got a discharging ear, you've gone to town with all your stuff, what might be going on?
Cholesteatoma.
Yeah, Todd, do you mind sticking on the next slide? Yeah, so when you look in the ear canal, the eardrum never looks like these. So this is done with a fiber optic camera. I hate it how in your picture you always see the whole thing, because that's not what happens. Very rarely can you see someone's whole eardrum, and for some people you can see like 30% of it or less if they've got bony growth. But anyway, the one on the right is a normal looking ear, and the one on the left has got something in the attic. So that is the common spot. So when I said I think it's good when you're syringing ears for you guys to have a look pre and post, part of the reason is this. So when you look in an ear, you should always look up at the attic. That's the most common spot people get cholesteatomas. They can get them elsewhere. It's just a growth where they get a pocket pulling back because the eustachian tube's not working properly, and they get an abnormal growth of skin and keratin cells that can be really destructive if left for a long period of time. So always, when you look in an ear, make sure you look up at the attic, because that's the spot. And they can be subtle, and they may not have any symptoms when they first get them. Any questions, guys? Sorry. No worries. The next slide, please, Todd. So just on micro toileting. So what it is like I said to you guys, it's just a microscope. I don't know if you've all seen it, but you're basically just looking down the scope with a speculum, sucking out the wax. And the people who need it are the ones that can't have their ears syringed. So not everyone needs this. It's just people who can't have it syringed. So the common people that I would see in the clinic are people who've had radiotherapy on their ears. So anyone who has their face irradiated for a skin cancer usually, or a parotid tumour, invariably part of the problem is it damages the skin in the ear canal, and that will often break down, and they'll end up with really adherent wax and skin, plus or minus bone showing through the skin. So radionecrosis is very common in the ear canal years after radiotherapy. So they're the people we see quite a lot. Anyone who's had an operation, so mastoidectomies or chronic perforations, recurrent otitis externas, people with hearing aids who don't like their ears syringed, so we see a fair few of those. Fungal otitis externas, anyone with a grommet or who's had a grommet in the last 18 months shouldn't have their ears syringed. And we see a lot of exostosis, which I think, show us the next slide, Todd, I think. Oh, no, it might be in the quiz, actually, that one. Yeah, so that's basically bony growth in the ear canal, usually from exposure from cold. So surfers and swimmers again. So the pros of doing microtoileting are you can see what you're doing. So you're unlikely to perforate a drum. You're not using water, but we do often, I use a bit of peroxide often just to fizz things off if it's safe and they haven't got a perf. Obviously, it's safe in people who can't have syringing, and sometimes it's essential to treat conditions. The cons of it, I don't know if anyone's ever had it done, it is like a 747 in there if you can hear. A lot of people get vertigo, even just by putting the sucker in there. So, and the closer you go to the drum, the more likely you are to get it. If you touch anyone's drum, apart from being acutely painful, it'll give everyone vertigo across the board. So for 5 or 10 minutes, if you suck on someone's eardrum, and it's quite expensive. So in our practice, we charge privately $130 if someone needs both ears done, and they just get back the consult for Medicare. It's a bit of a trick. I don't know if any of you guys are doing microtoileting, but a fair few GPs have had to pay back a lot of money to Medicare for overbilling the Medicare item number for that. So you've got to be quite careful. Any questions, guys? No worries. The next slide, please, Todd. That's the last one coming up. So the last thing I thought I'd touch on is just hearing tests and tympanograms. So I found them very difficult to interpret, and still have to look at them. There's too many things going on for me on a pure tone audiogram. So, you know, too many marks and things. But the gist of it is they are something that's really useful if you've got someone who's struggling with their ears. And obviously there's two common types of hearing loss. So sensory neural loss is basically inner ear hearing loss. There's no cure for that. And so basically the treatment is aiding of some type, and that includes cochlear if the hearing gets bad enough. And the common causes for that are time, so old people, noise exposure, and infection can also cause that if you've had multiple ear infections, particularly in youth. Now, conductive, on the other hand, is any problem with the air conduction getting into the middle ear, and obviously there's loads of causes for that. So that can be infection, wax, you know, pole in the drum, fluid behind the drum, etc., etc. The fusing of the little bones in the ear, a cholesteatoma, and those things are all, you know, a lot of those are potentially treatable. So, you know, perforation can potentially be repaired. Cholesteatoma needs an operation. Otosclerosis can have an operation. So, exostosis can have an operation. So these are things that might need or are likely to need review. I just want to point out that if someone suddenly comes into you and says, I can't hear, last night I lost my hearing in one ear, and you look in there and you can't see a reason, as in there's no wax or they haven't stuck something in there, that's a medical emergency. So you need to speak to the ENT registrar, touch base with them, and usually that'll be a big dose of prednisone and an urgent hearing test, and then review shortly thereafter. The other thing, when you get a pure tone audiogram, so if I send a patient for a hearing test, I usually ask them to do an audiogram and a tympanogram, and I'd say to the patient, don't just go to the one in Charlestown Mall where you walk in and do one for free. It's much better if they pay for a good one, or they go to Australian Hearing and get a proper audiologist, to do it, because you'll often get told useful information. So the tympanogram tells you if the eustachian tube and the middle ear are working properly. So that means the eustachian tube's opening and the middle ear is aerated. It'll tell you if they've got a problem like a hole or a cholesteatoma, because often that'll just be like a flat line that nothing happens. It'll also tell you if the drum's not moving properly or if it's normal. So, and usually you'll find on the bottom, you would have seen all these, the audiologists will invariably say this probably needs referral. And in fact, they usually say needs referral. But I would say if there's a conductive hearing loss and you don't know why, then it's probably something to think about. And that's the ear talk, guys. Any questions at all?
Julian, I was just going to say that I'm glad you mentioned that, because I reckon 90% of the reports I get back from audiologists say, in light of the asymmetric hearing loss here, do you think an ENT referral is warranted? Like, I don't know. You're the audiologist. You tell me.
Well, I think the answer to that is if they've got more than 15 decibel hearing loss across multiple frequencies, and you got it's new and the patient, and it's a sensory neural loss, that's a reason to refer. Or you can, because the rare thing that you want to rule out usually in a sensory neural loss with you know, a unilateral is just that I haven't got an acoustic neuroma, which is so rare. But you do occasionally find them if you do an MRI of the eye, the internal auditory mediates. But yeah, I think that usually it'll be if they've got a conductive loss, Chris, I think. And so yeah, and if you have a look and you can see a cause. So I guess the thing is, just because someone's got a tympanic perforation, it doesn't mean anything has to be done. If it's been there forever and it's dry and it's not causing them problems, and you'll find often, so you know, repairs of those don't always work. You know, they might fail, I don't know, 40 or 50% of the time, but yeah. Any other questions, guys?
I've got a question. So yeah, obviously sending patients to get some, you know, microtoileting with a severe otitis externa or whatever is quite expensive, and there can be a bit of a waiting list. So if a GP was interested in upskilling, how would they go about training in that? As you mentioned, a lot of doctors were billing the item numbers incorrectly.
Well, the hard part, I suppose, there's two things to say about that. On the Medicare side of things, it's so confusing, and I still don't really. So the item numbers are 41647, and that's for you know, microtoiling near using an operating microscope, so that you can get a good look at the tympanic membrane, you know, whilst you're doing it. That's the idea. That's the Medicare. So if you read that, you'd be like, no worries, I can bill it for just about anything when I use a microscope and suction it out. And then the Pharmaceutical Services Review then made it extremely specific and said it was only for erosive otitis externa, but that's not common knowledge. And that's not actually what anyone uses it for. So the ENT surgeons bill it for any time that they use an operating microscope. And I guess I just do it. I still bill Medicare, but I do it for those patients that have got perforations or have had operations, because how else can you do it? I think I don't want the patient to pay for something, you know, it's not their fault, and there's a skill involved. So, and I guess if I get it audited, then I'll probably just have to pay back. I think to learn how to do it, there are courses. So there's a nurse at the moment at our practice who's learning how to do it. So there's an online course, and then obviously she's got the advantage of just sitting in with me, doing it with me, watching her or not, because I've got a TV screen where you can see what's happening while they're doing it. So yeah, so I'm always happy to teach people how to do it if they want to learn. But there are courses for this. Sometimes people use, you know, the vortex, like glasses, and then just the speculum. You could probably get away with that. And certainly when everyone was starting to do a bit of it, because it was a good thing to bill, people were just getting the microscopes and teaching themselves. It's quite an easy skill to learn. I'd say once you've done 20 of them, you feel reasonably comfortable. If you've done 50, then most of the time, you know, you'll be feeling okay. So it's just access to getting the scope and things, I think, is the thing. Yeah. So there are. Sorry, mate.
Sorry, can I just say, probably at the other end of the spectrum, that I always used to, you know, in the days of yore, I used to kind of feel a bit embarrassed about ringing up an ENT doctor about otitis externa, or I just got this feeling like this should be something I can do. This shouldn't get out of hand, you know. And it kind of took me a while to figure out there's a top end of otitis externa where people end up in hospital, people need specialist care. And you know, it's quite legitimate to do your GP stuff, and if it's not working, that's just, you know, that's just kind of like, well, that's the way it is, you know. So I'm not. It took me a little while to get over this reticence to ring up the ENT doctor saying I've got somebody, you know, with goo in their ear and I don't know what to do. So they all seem pretty happy about it.
And they are, and I think you're right. It's not our fault as GPs. It's not your fault, is it? It's just you've done everything in your skill set, and sometimes something else needs to happen. You know? Yeah, absolutely. Yeah. Yeah, and they can be, mate, I can tell you that can be really difficult things to manage. Getting otitis externa can be a real bugger to get on top of.
Yeah.
Yeah.
It can also be very difficult to get them into ENT. That's what I've found the problem is actually finding someone to see them if they can't pay privately. Usually you can get someone in privately.
I think even if you're privately covered, say, I don't know what it's like. The Central Coast is better. I was actually sending people down your way from my clinic because you couldn't get anyone in to the public system in Newcastle. I know because I used to work in it for years. and then even privately, there was like a 6-month wait. Like even the only people I know that I can get people in are hideous head and neck cancers. And they'll see those guys quickly, which is fair enough, but pretty much nothing else.
Well, I might have been lucky because, you know, when I've rung ENT doctors and said, you know, this is otitis externa, it's full of goo, I can't clean it out, I'm going nowhere. They treat it like a foreign body in the eye. You know, they'll see them within 48 hours.
Sorry, John, I think, so you're right, mate. In that instance that you're talking about, calling the hospital, probably the person on call, and they'll do it in the hospital usually. Is that what you mean?
No, even the ENT doctors. Maybe I just been lucky.
They must like you, mate. They must like you.
Sympathy, you know.
A touch, John. I'm gonna have to learn from you.
I know a few of them. I can get people in, but I think you've done well to get them in quickly. But you're right, that is an acute thing though. So if I was worried, so I occasionally do call up the ENT on call, the reg or whoever at the hospital, and say, look, I've got this situation. They'll invariably see them. There is an ENT clinic where you'll get people in acutely if you're worried. I mean, it's like those slightly more subacute things that are really difficult. Yeah, like a cholesteatoma, for example, in Newcastle. If you have someone with that and they're not privately insured, you'd think that would be urgent, but that doesn't get seen that quickly.
Okay, well, thanks for that, Julian. That was fabulous. Great tips there. I'm sure everyone's going to go find some courses in microtoileting so they can as well. Really good practical tips there.
What's the cost of the equipment?
You know what, Cosmos? I don't know, because it was all there when I got there.
It cost about $10,000.
10,000. We'll need a price check on that.
Yeah, I think there's different things there.
Yeah.
That's what I was going to say. Is you'd have to do a lot of these to actually pay off the equipment in the first place.
Yep.
That's why it's just not.
And that's not inclusive of the microscope.
Mm.
Yeah, you're right. You need. I think if you're in a big practice, you know, and you had the patient load, you may be able to make it work. But you're right. You need a lot of patience. Yeah.
Okay.
Yeah.
So I think it's time for us to move into our little group. So we've got some 3 skills sessions group. So station 1 will be with Julian with an ear quiz. Then station 2 is assessment of the eye with myself, and then eye emergencies with Chris Starling. So when Todd's ready, he'll put us into groups. Hopefully we don't get too lost. And then we'll come back afterwards and gather just for feedback and lucky door prizes, etc. And we'll go from there.
And Todd, I was just wondering, should we do 20 minutes for each group just to keep?
Yes, I think 20 minutes each group will be fine.
Sure. Let me adjust that for you right now. Just a reminder for all the participants, you will go into a group and stay in that group for the next hour. And what will actually happen is at every 20-minute mark, I'll let the facilitators know that it's time for them to leave the room, and a new facilitator will pop back in. So that'll keep it nice and simple. And opening the groups now. Enjoy your time.
Fingers crossed.
Yeah, that's right. I thought we had a bit more time up our sleeve, but there you go.
Okay, we've finished.
Oh, we got cut. I thought it was my computer that cut off. I was like, oh, it must have been a. I might have to apologise.
I'd say what's happened there, everyone, just so you're aware, is that obviously we said an hour for groups, and I guess between the changeovers and a bit of floating around, that last group got really compressed. So apologies for that. You got halfway through your spiel.
Hello.
Cool. And people probably do want to head off.
Yeah, someone kicked me out from Georgia's room. What did I do?
That's right. You're out. That's
Nothing wrong, mate.
Just kicked out.
The time limit just. That was it.
No, it wasn't. We just started.
I know. There's a few teething issues, Cosmos.
Yeah, that's right. Teams is not being
a problem. I'm happy to be sent out for some time, you know.
You're in detention, mate. You're in detention.
In the naughty corner.
Yeah.
So we're just waiting for Georgia to come back.
Okay, cool.
And then we'll do.
I think we might have to do paging Georgia to the lobby, please.
Yes.
Yeah, she's obviously had trouble. She's been running around in somewhere.
Just let me know that she's dropped out, so she's trying to get back in.
Yes.
yes, I saw the countdown happening, but thought Todd would probably would adjust for it.
I think it's got a mind of its own.
Once we kind of launched into the groups and they were set to an hour, unless you kind of cancel the groups, it literally sticks to an hour, unfortunately. So I guess
Right.
chewed up a bit too much time between the lobbies. Sorry about that.
Yeah, that's all right. So that's all right. We'll just wait for people to try and manage to make their way back. And
I think our talks will be available, won't they? So apologies to our last groups, but our PowerPoints will be available, so we can work through them.
Yeah, I'll send a link to that for you as well for everyone. And I just want to remind everyone while we're waiting, just the Slido evaluation. It's really important that you give us your feedback, and we'd really appreciate that. So that's www.slido.com, and the passcode is #GPC.
I think
and
Georgia's
Todd,
being...
if you could help out with Georgia,
she's got access denied. Oh, there she is.
Goes.
Okay.
We still love you, Georgia.
Georgia, you kicked me out of the room. What did I do?
I just dropped out and I heard a beep and I'm like, I'm talking to myself.
I thought you sent me off. Naughty Cosmos out.
It's okay. You can get a copy of my slide, Cosmos, my slides, and hopefully one of the other ones were recorded so you can do some revision on how to assess the eye.
Not a problem at all.
Yes. No,
Excuse me, Nell, it's Karen. Nell,
Yes.
could you give us the Slido address again, please?
Yep, sure. So for evaluation for everybody, it is www.slido.com, and the postcode is GPC. The hashtag's already there. You just have to put GPC in.
Cool.
And there it is on the screen. Thank you, Todd.
And hopefully, I mean, so I think we're aiming for face-to-face for the next one, aren't we? So I think it'll be a lot easier than...
Yes. We shouldn't get kicked out of the room when we do
that's
face-to-face.
right. Unless the uni says get out.
Yes, the next GP Club, we are aiming to go face-to-face, and that will be on May the 19th. So you'll get an invite for that very soon.
Yes, and it's going to be a great lineup. I'm very excited about it. So, and excited about seeing you all face-to-face as well. So,
Cool.
all good. And I will also do before we go a little plug too about the vertical integration sessions. I'm not sure if all of you are aware of those sessions that are held usually every second Wednesday morning at 7:30 to 8:30. They're in a Teams format, but we don't try and break off into different rooms and lose you. But they've been great sessions so far. So we've had dementia, we've had lifestyle medicine, we've had contraception, dermatology, child and family health. So they've been really good topics that are interactive. There's something in it for everybody, whether you're a medical student, a resident, or an experienced GP. And our next session is next Wednesday morning on chronic disease management. So that would be good. And the one after that is actually an evening one on wound care 101, because let's face it, us as GPs, we're not very good at wound care. Well, I know I'm not. So I'm hoping
we don't do them anymore.
I know, but when the nurse isn't there, we need to know. And I look at all the cupboard with all the dressings, and I'm like, what do I do?
You just say go to the community nurse.
Yes. They're not always available, especially if they're in your room.
That's right. And they come back to you though. Then they say,
Cosmos, I need you to
dress
dress my room. So that's an evening session, because that will be a more popular.
We used to do a lot of wound until Medicare took out the item number.
I know.
So you're like, damned if you do, damned if you didn't. You were doing wound at cost to yourself. So
yeah, it's hard, but you just have to pop in with a nurse while they do the work and have a look at what they're doing. But that would be a good session. So I look forward to seeing you there, Cosmos. That's in 4 weeks' time.
I don't do wound. I just say
I'll be looking for you. I'm watching. Yeah, all good. So yeah, so and we are hoping that there's a session coming up where we'd like some doctors just to do just present an interesting case as well. So in a few sessions time we'll be just doing some case discussions. So I've got a case I'm happy to talk about, and if you've got any, it doesn't require any preparation. If you want to do some slides, you can, but just good old case discussions of an interesting case. So we'll do that as well. Would you like me to do the wrap up now, Melissa? Did you do a bit of a wrap up when I was missing?
No, we've just gone over the Slido.
Julian, you've been eating all day long. What's going on?
Marguerite, would you to you before we leave? Or
No, I think we can just move on and all go and get our late dinners.
for sure, yeah.
Julian's just finishing his.
Yep.
Yeah.
Sounds
a few, but otherwise it's been a great night. Over to you, Mel.
Thank you so much. So I'll close the event. Just a quick reminder about the Slido. It is www.slido.com. The passcode is GPC. So please, we ask you to fill that as well to get that feedback. Thank you, Georgia, for facilitating tonight as well, and Chris and Julian for presenting. It's been a great night. The interaction and the conversations have been wonderful. And thank you all for being with us tonight as well. So go relax and have a lovely evening.
Thanks, guys.
Thank you. Bye bye,
Thanks everyone for coming.
Thanks, guys.
We hope to see you soon.
Bye.
Take care.